All right, well, I've got 7 o'clock here. I hope you guys can hear me okay. Nobody's texted me that they can't. I'd like to welcome all of you to this presentation here, and thank you. You'll notice in the chat, you can type in your questions that you have. You're welcome to type them along the way if you want, or you're welcome to do that at the end, but that's where I'll be going through the questions. It's just through the chat, so feel free to add your questions there. So as a brief introduction, for those of you that don't know me, I'm Dr. Michael Brown. I'm board certified in family medicine. I'm also board certified in clinical informatics. And this presentation is called Telemedicine, Practicing Medicine in a Pandemic. And what I'm hoping to get out of this lecture or talk tonight is to kind of help you see the rules and the changes that have occurred with telemedicine before COVID-19 and then after COVID-19, to show you a couple of different workflows that I use for telemedicine that you might be able to implement, to briefly discuss the technologies that we can use for telemedicine, and also to talk about how to determine what things can be handled by telemedicine or what cannot be handled. I'm going to hopefully fly through a lot of information here so that I can leave some time for questions, because I think that's the most important part of this lecture, is you being able to ask me those questions. The fact that you're here probably tells me that you're very interested in discussing new ways to deliver care to your patients, and I'm hoping that I can be able to give you some help or some ideas, and maybe you can even give me some ideas on how I can improve what I'm doing as well. A little bit of background on me. I am currently a full-time family medicine physician. I practice full-time in a small town called Smithville, and smaller than some of your towns and larger than some of your towns. So it just depends on where you're practicing. I am the president-elect for MAOPS. I was the former assistant CMIO for Mosaic Life Care, and also their former director of telemedicine until I went back to practice full-time. And I'll talk more about my experiences doing that as well, and how that's influenced telemedicine within my practice. I helped create the first direct-to-consumer telemedicine program in Missouri. This was actually several years ago when the regulations were very stringent and very tough. It was a very difficult process, and it took us a few years before we could get it off the ground. I also trained and operated a full team of nurse practitioners when we were providing this service. We found that nurse practitioners at the time, with what we were limited in scope of being able to do, did very well with the telemedicine project when they were directed by a physician led team. I currently, though, operate a practice that fully blends live visits with telemedicine, and I'll show that a little bit later on what I'm doing in my practice today. This slide is to remind me and to remind you that all of this information is new. This is information that's only about 3 to 4 weeks old. So this is my disclaimer saying that I'm doing my best to give you current and relevant information, but it changes day to day. And telemedicine now and telemedicine a month ago are two different subjects and two different topics. And so we've had to revise all our slides, revise all our information, because this is a new field of medicine. And so we're going to talk about that. So before COVID, I just want to give a little bit of history about why was telemedicine not so widely adopted? Why were doctors not practicing telemedicine that much? And it was because there were some very serious concerns that really limited its functionality. Number one, it was poorly reimbursed. Providers wanted you to get a quarter of the payment for, getting the same results. And so it was very hard to make a living doing telemedicine when you could see one patient in your clinic for every 4 you'd have to see by telemedicine based upon what they were providing. There were certain physicians that did make it doing just telemedicine, but they had to do just telemedicine. So they had to have huge high volumes in order to make it well reimbursed. So it wasn't very practical for a standard family medicine clinic to be doing telemedicine in between seeing actual patients in their clinic. Two, there were some very high technology costs. It was very regulated, and because of this, you had to have some very special technology, you had to have special services, and you had to have special rules and regulations that were very expensive. And so it made a high barrier to enter into telemedicine. And then lastly, there were some very complex processes, both for the physician and the patient. To get properly paid for it, you had to have very complex processes. To have the appropriate technology and the appropriate security, you had to have very complex processes and had to use special programs that were qualified and certified for it. And then your documentation was also complex. Basically, a higher standard of care was being applied to somebody providing telemedicine than somebody seeing a patient for the exact same thing in their clinic. And therefore, it made it a little bit less palatable to jump into the telemedicine world. This is just an example. You do not have to get anything out of this workflow other than I share this because this is what my decision trees and workflows looked like before COVID. This was all the things we had to do just to determine whether or not a patient was eligible to even do a telemedicine visit. And it was because of all those complex regulations that we had to meet. And so very complex workflows. So you can see why it wasn't adopted widely. So everything changed on March 17th. That is when the Trump administration announced expanded Medicare telehealth coverage. A direct quote from them was that CMS will temporarily pay clinicians to provide telehealth across the entire country. And at that same time, or within a few days, most states actually enacted emergency changes to support this, including the state of Missouri. And I'm going to cover some of the regulations and changes that occurred specific to the state of Missouri. But this was a big day. This is where a few years ago, if you'd asked me when worldwide adoption of telemedicine would be, I would have told you about 5 years ago. Well, we still had 3 years left to go in my prediction. Or I would have told you it would be about 5 years until it was worldwide adoption. Well, we're about 3 years ahead of schedule thanks to COVID. I would call that a silver lining, but it's really hard to call anything a silver lining given what's going on right now with physicians and our patients. But I will tell you, if there's anything good that has come out of COVID so far, for me, it's been the advancement of telemedicine and the ability for us to give care and be appropriately compensated for that level of care doing remote medicine. These are some direct quotes. I do want to go over them just because there's some very important things that you need to understand from them. I try my best not to just read things from slides, but this is an important slide for us to understand. So this is part of that March 17th announcement. It says clinicians can bill immediately for dates of service starting March 6, 2020. Telehealth services are paid under the physician fee schedule at the same amount as in-person services. That's a big deal, and that's why I put that sentence in bold. And then I also put in bold at the end where it says there's also flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits. This is also a big deal. It was very difficult doing telemedicine before and trying to bill insurance because you had to also collect those copays. You had to do it appropriately and in the same way you would do it in your office. Again, a higher standard of care was given to remote medicine than if you just saw the patient in person. So people would just default to inconveniencing the patients and making them come in to see you for things that could easily have been done in a telemedicine visit. One of the rules that was before COVID was that you could not prescribe to somebody who was not already a patient under your care. So there were many state laws around this. The state of Missouri had a law, but they waived this immediately. They said to the extent the waiver requires that the patient have a prior relationship with a particular practitioner, HSS will not conduct audits to ensure that such a prior relationship existed for claims submitted during this public health emergency. What that means is that you can see telemedicine patients that you have not seen in the past. There may be some complexities with your health system or your electronic health record, but those can be worked around and you do not have to have a prior relationship with the provider to provide telemedicine. It's just one less hoop that you need to worry about when you're doing telemedicine, and it makes it a little easier to be providing telemedicine and not worrying about whether or not you've seen them recently or they're what you would consider an established patient in your practice. I will tell you this though, the national telemedicine chains have been getting around this rule for a very long time. I don't really know how, but they have somehow been getting around it or just ignoring it. So this really wasn't a big deal to some of those national chains that have been providing telemedicine for a few years now within the state of Missouri. Where can the patient be? This was something that Medicare required them to be in a specific location, like another clinic. But with these rule changes, Medicare will make payment for Medicare telehealth services furnished to beneficiaries in any healthcare facility, and we put in bold, and in their home, meaning that the patient does not have to be in a special clinic like they were requiring previously to this. This slide is a busy slide, but this is directly from the CMS release of information about different telehealth visits. So I'd encourage you to go to that official release if you'd like to get more out of it. What I want you to get out of this slide is that there's 3 major types of telemedicine services that Medicare or CMS uses. What we are talking about tonight is that very first one, Medicare telehealth visits. There are also things called virtual check-ins and e-visits. The virtual check-ins are actually a code you can bill if you just do a telephone encounter with a patient just to decide whether or not they need to come into an office. If they come into the office in the next 24 hours, you cannot use that billing code, or I believe they need a procedure or something in the next week. I don't quote me on the exact rules, but basically that's how it works. What's interesting about this, and I've been giving heartburn to my clinic managers and to my administrators on, is that technically you can bill this when you're on call and a patient calls you and asks you a clinical question. We've just never been doing it before, but people's minds are all thinking about lots of different things now during this crisis, and we're providing a lot more telemedicine visits. E-visits are a special type of visit that is a non-concurrent type of care. So during a telehealth visit, you're live and the patient are live at the same time talking to each other. During an e-visit, the patient logs into a portal, maybe types up their symptoms, puts a picture online. You then later review that and then send them back information. So that's what e-visits are, and there are already established codes. These are all codes that you can bill Medicare patients with, but we are going to focus on this, telehealth visits. And the reason we're going to do this is because this is where the government has said that we will pay you like a inpatient visit, like a patient is visiting you in your clinic, and you can use your standard EMM codes. And we will say, and I can't remember if I go over this later, so I'll tell you now, there's a modifier that they ask you to use. It's modifier 95, and there's some documentation requirements that we can talk about as well. But just know this, we're talking about Medicare telehealth visits. Most insurers have all fallen in line with this, and we'll talk about that in a second. Another question that we get quickly asked is, what about HIPAA? This was something that really made telemedicine difficult. You know, how do we keep the HIPAA regulations? We had to use very expensive services that wanted us to overpay them for services that were being done for free through other different services, but because they had the HIPAA branding, we had to pay them, and it made it a very much huge barrier to providing telemedicine. This was kind of a cool change, I think. It said effective immediately, HHS will exercise enforcement discretion and waive penalties for HIPAA violations against healthcare providers that serve patients in good faith through everyday communication technologies such as FaceTime or Skype during the COVID-19 nationwide public health emergency. What this means is that if you don't have an expensive service, you don't have an expensive program, you can use FaceTime. You can use Skype, and we're going to talk about that a little bit later in this presentation. One caveat that is in sort of an FAQ or a FAQ that is done by the CMS, they specifically say in there that for you to bill those EMM codes, like your 99213s or 99214s, the provider must use an interactive audio and video telecommunication system that permits real-time communication between the distant site and the patient at home. This does mean you need a video requirement at this time to bill that higher code. Now you can go and drop down to those other codes that we talked about just a few minutes ago, but if you want the higher code, you've got to use video at this time. Now I know for a fact that AOA, I was just reading one of the briefs, they are trying to lobby to make it so that telephone gets reimbursed just as much. I completely support and agree with that. I think that a physician should be reimbursed based upon the service that they provide, not how they provide that service. So if I get paid one thing for treating a cold in person, then I should get paid the same amount if I treat a cold over the telephone. Obviously right now the waiver doesn't agree with that, but again, they are working on that. I just think that telephone is telemedicine as well, and always has been. So remember, medical licensure though is a state issue. So while there were all these waivers that were made nationally, we still are licensed by the state of Missouri. Now Missouri got in line very quickly with the federal government, but if you are practicing, excuse me, if you are practicing in a state where your patients are outside of the state of Missouri, then you're technically practicing in that state. So telemedicine is practiced in the state or the location where the patient is, not where the physician is. So you'll want to check with those telemedicine laws. Now, I will tell you that most of our surrounding states, such as Kansas and Iowa, which are the only two I've looked at really in depth, they have all gotten in line with all these regulations. And most states have waived the requirement for you to be licensed in that state. You just have to be licensed in a state to practice telemedicine. I'm sure this is giving a lot of heartburn to the federal state medical boards right now. But essentially, you do not have to be licensed in the state of Missouri to provide telemedicine in the state of Missouri. You just have to be licensed in a state. So Missouri Medicaid has chosen to cover telemedicine similar to Medicare. So if you take Medicaid, Medicaid is covering telemedicine. They have waived the need for an established relationship, just like the federal rules were waived. They've also waived the need to be established prior to prescribing medications. Missouri had a rule that you could not prescribe a medicine to someone you had not established a relationship with. They have waived that, and you do not need to be established. Essentially, they've also said with this same rule that you could provide controlled substances or any type of medicine by telemedicine. They've also waived the requirement that you be licensed in the state of Missouri to perform telemedicine in Missouri, and we just talked about that. And as I said, I'm sure there's a lot of heartburn going on because of this. It'll be interesting to see what happens to state-based licensure when all the dust settles here, and people are suddenly being told, "Oh, you could practice in Missouri. Now you can't practice in Missouri." We'll see what happens there. These are some links that I provided. We will make available both of these links for you in some of our resources for this after this presentation. But just know that both of these are websites that have updated laws on a state-by-state basis. So if you want to see what Kentucky is doing, or you want to see what Illinois is doing and what their laws are with the post-COVID changes, these are in these resources. What about commercial insurers? This link here is a great resource. It has it's American Health Insurance Association, and basically they have what health insurers have done post-COVID and what changes they've made. An example I shared with Blue Cross and Blue Shield of Kansas City, which is large in my area. This is one example of what they're doing. They've waived cost sharing for COVID-19 testing. Those are your deductibles and your copays. The company is also waiving refill limits for 30-day maintenance medications, as well as fees for urgent and sick virtual visits. Essentially, they've waived the copays for patients doing telemedicine. The only person that my billing department right now is telling me I need to be very careful with is Cigna. Apparently, we're having some difficulty with them. That may have changed. I haven't followed up with them in the last week, but that's what we were initially told a couple weeks ago. Other than that, most of the commercial insurers are reimbursing us pretty well for telemedicine. Picture of me there, that was taken several years ago. It's one of my favorite pictures because it was always my dream that one day I would be doing telemedicine with a patient. They'd be sitting at home and they wouldn't have to come into the office. And, you know, this last few weeks, it's just become such a fluid part of my practice. Before I felt like I was pulling teeth to be able to do telemedicine in my clinic. And now I'm having patients wonder why they would have to come in and see me. In fact, most of my arguments with patients these days are over whether or not they should come in to see me for a visit. They really want to do something by telemedicine that maybe I'm not comfortable with, and I have to put my foot down and say, no, you do need to come in for that versus doing telemedicine. But I'll tell you, as we'll discuss later on, more often than not, I'm trying to get people to do telemedicine versus coming in to see me. So since March 19th, how has my practice changed? I'm very fortunate to have very supportive administration. They were very fast in adopting these rules. They authorized us right away to use private video conference technology. And this was widely accepted among our providers. In fact, I was impressed with how many are using them. I even have my OBs now doing it. They were probably the last holdouts, but they've been doing OB visits with patients. My wife is 30 weeks pregnant right now, and not because her husband's a doctor, but she's absolutely refused to go into her OB's office. They called her multiple times, and she said, I'm not stepping one foot in that hospital right now. They finally started doing telemedicine with her, which has made her much happier. So I'm glad that they've adopted that as well. I know one of our neurologists and one of our members, Dr. Sarah Hahn, was telling me she's been doing these with her neurology appointments, and they've been very successful. I have family medicine physicians in our system that I never thought would be doing telemedicine that have just been doing it, and they've been loving it, and it's just been working very well. we started using FaceTime, we started using Skype and Facebook Messenger. Those were my main primary sources. Some would use some Google Hangouts. I didn't have as many patients wanting to do that. But most of us have switched over to a more consistent platform. And the one I like right now is Doxy.me. The reason we did that is it gets a little tiring switching back and forth between one and another. And we found a consistent platform that a majority, and I'd say more than 95% of our patients are able to use, and able to use it very easily. And because of that, we switched over to just using that service. But I'll talk about how you can use the other ones. I do fall back to FaceTime, Skype, and Facebook Messenger when the patient isn't able to use the other service. This is a workflow that you're welcome to use, and I do have a PDF available that we'll make available to you as a resource. This workflow is very simple in the sense that it just helps get our patients scheduled for online. My front desk staff have just gone wild with this, and they've done a really good job of getting my patients scheduled for telemedicine when they don't need to come in. Essentially what we do is the patient can either see me by scheduling online or by calling for an appointment. When they call in for an appointment, if they have cold symptoms, we automatically make them do a telemedicine visit. We don't give them a choice. They have to be triaged by telemedicine first. And so we do that, and then we determine what to do with them from that point. We have a special clinic that we send people with COVID risk symptoms, or people that we think should be COVID tested. We send them to one special clinic in the system, and that keeps COVID. Well, the goal of that is to keep COVID out of as many clinics as we can, and just to this one clinic. We then ask the patient, though, if they don't have cold symptoms, if they would like a telemedicine visit. If they do, we schedule them for a telemedicine visit. I then review the schedule every day, and I look over appointments, even appointments that wanted to see me in person, and I ask myself, is this visit telehealth eligible? If it is, I ask my staff to call the patients and offer them a telehealth visit again, and see if they would like to do telehealth visit. If they don't, then we just schedule a normal office visit. But the goal of this workflow is to get as many patients as I can using telemedicine so that I can keep the COVID exposure low in my clinic. It's worked very well so far. It's given me a very even mix, as I'll show you later, of telemedicine and people seeing me in the clinic as well. As I said before, this workflow emphasizes telemedicine over in-office visits. And the physician has full control of the schedule, so you need to review it frequently to help your staff with it. Some tips that I've found over the last month of doing this is I have a younger staff member who's one of my schedulers, and she is just so gung-ho over this, so I kind of put her in charge of the telemedicine scheduling. She does a great job. I even gave her a laptop with a webcam, and so she actually, not only does she get my schedule full telemedicine visits, but she also will help them get logged into our service that we use prior to seeing me. So when they're ready for a visit, she gives them a call, she gets them set up, and she'll even webcam with them to do part of their check-in process, like verifying their insurance is up to date, making sure the technology is working. What's nice about this is it controls my wait time too. So if she knows I'm running behind, she'll say, it'll be about 10 minutes with Dr. Brown, or it'll be about 5 minutes with Dr. Brown. So this really works really well and has been going well. So if you've got a staff member like that, put them in charge of helping your patients get scheduled for telemedicine. This is another workflow that we will provide for you. This is just how I do a telehealth visit. And it just goes through that workflow I talked about with the access rep, and then me obtaining their history, and then what do I do if they need labs and such like that. But you don't need to get anything more about this other than if you're looking for a nice workflow, we've made one for you there. This is EHR independent. This is just more the workflow of how to get your staff and you passing the patient back and forth during a visit. So the technologies we're using, there was FaceTime, Skype, Facebook Messenger, and then Google Hangouts, and then Doxy.me. And I'm going to go over some of these. Again, I've preferred the consistent Doxy.me service. It's worked very well. But I started out using all these other ones just to get patients using it and getting my staff comfortable using it as well. One thing, though, if you're using FaceTime, you know that you can actually make it so that your caller ID on FaceTime is your work email account. So that way your caller ID is not your personal phone number or your personal email address. And to do so, you can go to these links that we provided. But essentially what you have to do is you have to load your work email onto your Apple ID account as a way for people to contact you. And so that's done through your settings and through your Apple account. But then once you've done that, then you can go to your caller ID under your FaceTime settings, and you can set that as your work email. And unfortunately, the steps to do all of this is much more than this presentation is able to do. So I provided some links there to do it. But essentially what will happen is that once you go to your FaceTime settings, if you've loaded your work email, it will be here as something that you can select as your caller ID. Then you'll be able to FaceTime with your patients, and it will be coming from your work email account. And not your personal one. I will tell you one device that's worked very well for me is I own a MacBook, and I'm not, people that know me know I do use Apple products because they work. But the reason I like the Apple products right now is because I can FaceTime on an Apple product, I can Skype on an Apple product, I can Google Hangouts on an Apple product. And so because I have that MacBook, it just allows me to use anything that a patient might be using. The other services like Doxy.me, as I'll talk about in a second, it works pretty good too. You can use it on anything though. But the nice thing about having the MacBook or MacBook Air or something like that is that I can easily connect to a patient using whatever technology they want to use. If the original technology fails. Skype, really easy to use or for your work account. Just go in, create yourself a new account with Skype if you're going to use Skype. Just click on sign in or create when you open up Skype. Click create one and use your work email. That way when you connect to your patients, you're using your work email. And you can even make it nice. You can put a picture in here like I've done. And so now I have a work account that I use for Skype so that patients just have my work email. The reason I encourage using the work email is because that way if the patient does try to reach out to you that way, it's in a place that you're checking, and it's also in a place that's got some security and protocols, hopefully, if you have this through your work. Facebook Messenger has actually been kind of popular. Some of my older patients have been using it to talk to their grandkids. Remember, this is not Facebook Live. You wouldn't want to be streaming a live telemedicine visit with a patient, but Facebook Messenger is an okay technology that you can use to communicate because it's one-on-one. It works easier though if you've had them added as friends. So my personal recommendation is you have a professional Facebook account, and that way you can add that patient as a friend, and then it's easy to communicate them with Facebook Messenger. All you do to use Facebook Messenger is you click on the little chat there, and then you put in the patient there, and then there's this little video icon, and that's the icon that you need to use to communicate with the patient using Facebook Messenger. Remember, again, this is not Facebook Live. Don't stream your telemedicine visits on Facebook. All right, so some best use ideas, as I just discussed: use your work email to create your accounts. And then as I discussed, the Apple products work really well. It's one dedicated device. It's also a great backup when other methods fail. For instance, I had a patient that was trying to Skype me, and he couldn't get his audio to work at all. And I could see he was like struggling with his laptop, but I could see on his desktop an iPhone just sitting right next to him. So I said, "Hey, what's your phone number?" Picked up my iPhone and FaceTimed it right then and there, and we were able to connect instantly. So that worked really well. So if they've got an iPhone, it's nice. You can just quickly connect to them if the other methods that you're using fail. This is an example of my schedule. So this was when I first started doing this, and it kind of took off. And the reason I show this is because I've always wanted my schedules to look like this, where I do telemedicine, I do something else, I do telemedicine, I do something else. It's just kind of cool. I never know, is my next patient going to be on my laptop or going to be on in my office? It doesn't matter. It's all medicine to me. And so it's really cool. What's even cooler is just this last week, this was one of my morning schedules. I was really, really excited about this. This was 8 telemedicine appointments in a row. Pretty cool. Worked really good. As you can see, I have my schedulers put what type of technology they want to use. They now are encouraging them to use Doxy, but sometimes they can't use it or they want something else, and so they put FaceTime in there. And so this is how I know what technology to communicate with the patient. We even have my workflow set out now that once my staff member has gotten them through all their check-in stuff, she actually hits print on the billing sheet, and she hooked it up to where she'll set the printer to my printer in my office next to me. So I'll just be sitting at my computer, and when the patient's ready, my printer will go off, and the patient's face sheet will print off there, and then I know the patient's ready, and I just log in and start chatting with them. So kind of a nice workflow. Again, train your staff to suggest telemedicine. This will help promote the telemedicine usage if they're suggesting it. So they can say, hey, would you like to schedule that by telemedicine? That seems like something. I would tell you, we all work with nurses, so we know them very well. My nurses are very encouraged to try to keep patients out of the clinic right now. They are very scared of getting COVID, and so they're very eager to suggest to patients to use telemedicine at this point. It's been working very well there. Also, encourage your follow-ups to be done by telemedicine. I've been doing lots of follow-ups by telemedicine, mental health follow-ups, or, hey, in 2 weeks, let's do telemedicine visit just to see how you're doing. I've even been doing blood pressure ones. I'd say, hey, do you have a home blood pressure cuff? Great. You're going to take it for a couple of weeks. We're going to do a telemedicine visit. Take it that morning. Let me know how it is. I can see what the blood pressure has been doing. If the blood pressure doesn't seem safe enough for me, or I question its accuracy, I'll have them come in and get it checked. Other things that I've done is I've had the patients come in for a blood pressure check from my nurse, and then they've left. And then later that day, they'll just do a telemedicine with me. That way they didn't have to stay in the clinic very long. Different kind of things like that. So think outside the box. Consider a workflow for labs and stuff too. Maybe you want a point of care testing, such as a UA or a strep test or a flu test. You could have them come in, do that test, and then they could do a scheduled telemedicine with you later that day. So consider workflows that you could do those labs. Or another thing that I'm doing is with patients that need labs that are just routine follow-ups, is I just will see them. I'll order the labs electronically through a Quest and just have them go to a Quest draw station, or they can come to my clinic and get them drawn and do that. So that's how I've been working with labs and stuff. Couple technical tips when doing telemedicine. One, always keep a good headset with a microphone near you, or in your bag is what I say, in case you need better audio. Remember, you have their contact number. So if you're really having a hard time with somebody, you can get the video feed, but you just can't get their audio to work. Call them up on your phone and put it on speakerphone. Then you've got a video going on your computer, and you've got the audio on the phone. You've made a good connection. And then also, always make sure you don't proceed until you've ensured that the patient can see and can hear you properly. So the first thing I always ask patients is to say, hey, Mrs. Smith, and I say, can you hear me okay? And she'll say, yeah, I can. And then you can move forward, and then you can hear them as well. Also, remember your background. Remember that HIPAA is still valid in all other ways. So if you're doing these in your office, make sure that you don't have a whiteboard with private patient information or patient lists up. So remember your background. It's always important to remember what you have in the background. Some other general tips: remember that you have proper grooming with the patients, at least from the waist up is what I always say. Proper lighting is very nice. Make sure your light is in front of you and not behind you. So right now I'm doing this presentation, and you can look at it when we switch back to the video, but I'm doing this presentation with a light that is behind me. I actually just grabbed a lamp from from one of my desks in my waiting room, and I put it behind the computer, and then that makes it so that I have a light in front of me. It looks so much better than if you're all dark. So just watch where your lighting is. You want the lighting to be behind you or in front of you, not behind you. We've all been in those phone visits with somebody that has really poor lighting, and you're like, I can't see you. Also, try to eliminate distractions: dogs barking, phone ringing. In my case, children banging on the door. Try to eliminate those distractions. Avoid shiny jewelry. It actually can distort the camera, and it gets your focus wrong. Patterns can distort the image. I was noticing I'm wearing a very poor shirt tonight that has a pattern on it, and it really does distort the image. Solid colors work better, and try to keep your workspace neat and clutter-free. People are looking at it. Some service tips: remember, opinions are made of you during the first few seconds. Be energetic, convey some sincere interest. If you have communication problems with people when they're in person, they're going to be 10 times worse when you're doing video. And when we were training people to do telemedicine visits, we always found that the people that were having communication struggles before really, really struggled with telemedicine. It made it much worse. Speak clearly, enunciate carefully. Help focus your visit. Make sure, just like when they're in your office, what are you most concerned about, and make sure you address that concern. Be sure to summarize with your patients. That shows that you're listening. It also helps to make sure you're communicating. Remember, with telemedicine, communication is your only real tool. So make sure that you are understanding them and they are understanding you. And that's good by doing that by repeating what you're saying or verbalizing it. And then always avoid complicated medical terminology. Say heart problems, say throwing up versus vomiting. A lot of people don't know where their abdomen is, so say stomach, and try to avoid doctor terms when we're communicating with them. So this gets into my, how do I know what I can treat by telemedicine and what can I not treat by telemedicine? I used to give very big, long lectures on this. Now I have like 2 slides on it. The answer is you've been practicing telemedicine for a very long time. And the question is, what would you do Friday night at 11 p.m.? This does not mean what would you do when you're cranky Friday night at 11 p.m., but what would you do for a patient that you really cared about Friday night at 11 p.m.? We should care about all our patients, I know. But what I'm saying is that when you decide what you can do with telemedicine, just ask yourself what you would do Friday night. If someone comes into you with UTI symptoms Friday night at 11 p.m., would you call them an antibiotic? I do. I don't make them wait till Monday before they're going to have to suffer. So you ask yourself those questions. What would I do Friday night at 11 p.m.? And that's how you base your treatment on it. So this answers a lot of questions. What if they need a lab test? Well, what would you do Friday night at 11 p.m.? Now we've gotten around this one because I can now order labs and they can just go to a Quest lab and get it drawn. What if they need a medication? Well, again, what would you do Friday night? What if the patient is angry or upset? What would you do Friday night? What if they need a higher level of care? What if they need to be seen in person? Well, if it was Friday night at 11 p.m., you'd send them to the emergency room. You'd send them to that level of care. So that's my one sentence way of saying this is how I treat patients with telemedicine. I ask myself, what would I do if I was on call? I've been practicing telemedicine since I got my first pager and my first cell phone. So we talked about some concerns when we started this lecture about why people were struggling with adopting telemedicine. We talked about how they're poorly reimbursed. Well, now we're getting paid the same as if we saw a 99213 or a 99214. We talked about the high technology costs. Now we're able to use what we already own. We're able to use our cell phones. We're able to use our laptops. We can use Skype, FaceTime, Facebook Messenger. Even that Doxy.me is all free. And then we talked about the complex processes. But now we have very much simplified processes. Our billing codes are the same codes. Our technology and security requirements have been waived. And our documentation is just our same documentation. I talked about how there's a few things that they ask that we put in it. One is that you make sure that you did it by telemedicine and you make sure that you have consent from the patient. The other one that they're starting to require by us right now is the patient at home, and are you at your office or you're at home? All I do is I say this patient visit occurred when at the patient's home and I was in the office or something like that. And then the other thing too is if you're using your documentation and you have templates, make sure your template doesn't say that the lungs were clear every visit. You might be able to slide by with that mistake occasionally in the inpatient setting, but if you said this was a telemedicine visit and your documentation says the lungs are very clear, I sure hope your patient had a very fancy Bluetooth stethoscope that you're listening to on the other end there. My overall take-homes from this lecture: 1, get your coders on board. Talk to your coders, make sure they are up to date. If they're reading any literature that is less than a month or more than a month old, then their coding education is out of date and they need to see what's going on with the codes right now and with your insurers right now. So make sure that they are not trying to put squares through circles and trying to apply the old rules to your current rules, because the rules have changed. They need to be on board with that. 2, get your IT department on board. That means get whoever helps you with your computers, whoever helps you with your technology, and that may just be you if you're your own clinic. That may just be you, but get on board with using the technology. And lastly, I'd say get moving now. This is a great service that you can provide. This is as easy as I think it's going to ever get when it comes to providing telemedicine. Maybe it'll get easier, I don't know. But I'll tell you, this is much easier than it's ever been in the last few years. Now's the time to start offering telemedicine to your patients. So with that, let me stop the sharing here. Let me start my video. Coming back to my screen here. And let's look and go through some questions. So as I said earlier, if you've got questions, feel free to type them into the chat on the side there. So that's the chat to all the panelists. And then I will try to answer those questions for you. So I'm going to go back to ones that are, so someone asked, will these provisions continue after the coronavirus crisis is over? The answer is right now they're written to not continue after the coronavirus crisis is over. But my question to that would be, what is the definition of the crisis being over? I have not yet seen an estimate that says that this is going to be over in under a year. So my point to that is that I have a feeling that they're going to qualify this as a medical crisis for a very long time. That's my own opinion, but I don't think that these rules are going to change anytime soon. The question will be, when it gets time for them to change, are all these state legislators and national legislators who have been doing telemedicine with their family medicine providers going to want them to change? And that will be an interesting situation. My suspicion is that we have let the horse out of the barn, probably not going to go back anytime soon. But I don't know. We could. I think that would be kind of crazy, and I think it'd be silly. I personally don't think it's going to happen. So, Dr. LaCour brought up a good point. She said she has a few patients stuck in other states now, Illinois and California. It sounds like I can't do a telemedicine visit for them, but could talk on the phone and provide refills. I will tell you, both those states, my guess is that you do not have to be licensed in that state anymore, and you probably could do telemedicine. Now, under old rules and old guidelines a month ago, you were absolutely correct. But you'd have to go to that link. You can go to the AOA telemedicine resources. That's where one of those links comes from if you want to. But I will tell you that that most states now have not required you to be licensed in their state to provide telemedicine. And it was the big states like Illinois, California, New York that made those changes first. So you probably could provide telemedicine to those states and be just fine. But I can't promise you that. You'd have to go look up the rules and the laws. But they are all in one document that you can look up on a state-by-state basis. Brian asked about some examples of when to not use telemedicine. I'll tell you, that's an interesting question. When should you not use telemedicine? In my opinion, you can start any visit with telemedicine that's not an emergency, and then you can decide during that visit whether or not it's inappropriate for telemedicine. And I've done that multiple times where I've had someone start off a visit with me by telemedicine and said, "Whoa, we need to see you in person." And maybe I made a few changes, had them write down some data from home and saw me before. But in my opinion, I try to do telemedicine for everything I can, and then determine at that point whether or not we should bring them into the office. That's just how I like to do it at this point. Someone asked, why can't children under 2 be seen by telemedicine? I think you were going from one of my old slides, and that was because at the time I just didn't want my nurse practitioners doing that. I didn't feel they had adequate training for children under 2, but there is no guidelines or stipulations at this point. There's no guidelines or stipulations at this point for the age right now. In fact, I've been doing a lot of teenagers. I will tell you this, and I bet a lot of you have had this happen too. My pediatric sick population has gone down to like 0 right now. It used to be like 40 to 50% of my practice. But since they've been out of school for over a month now, I haven't seen an ear infection or a cough or a cold or a strep or anything. It's just been sick adults at this point. So, but when I first started doing this, I did do telemedicine. I will tell you what I am still doing with kids though is their ADHD refills. Them being stuck at home with mom teaching them, boy, they really want to make sure they're on those ADHD medications. And that has been a great blessing for them to be able to do telemedicine for me. Yes, we should make we should make a PDF copy available of this presentation. I did give that to them today, and I'll leave Brian up to getting that out to all of you. Let's see. If you begin a televisit and then bring them back into the office, what is your billing? So for me, I don't know. So I don't know the exact answer to that one. That is a very interesting question that I don't have the full exact answer to. Talk to your coders. Here's what I do though. If I do a visit and it's just a quick, oh, I need to see you, I'm not going to bill for that telemedicine visit. I'm just going to have them come in and I'll just bill for that visit. But if I do a visit and I'm starting some care and I'm making some changes to a medicine, but then I want them to shortly follow up, I bill for both visits. Just like if they would see me one time, I make some changes and I want them to follow up. That's what I do. Now, how am I getting paid for that? I couldn't tell you exactly. My coders will have to answer that to you. But again, my definition is that if I'm getting paid based on, you know, the CMS definition was we're getting reimbursed just like we'd seen them in the office. So I billed just like I saw them in the office. And if that means I saw someone one day and I brought them back 2 days later for a follow-up, I billed them for both days. And it's been too short of a time for any of us to tell if they were actually covering that or not. I wish I could give you that data. I talked to my coders today and they said, do you really think we get paid in 3 weeks? And I guess the answer to that was no. So we don't exactly know how it's working right now, but we do know we're following the guidelines, and my coders have been trying to stay as up to date as possible and following their guidelines from their associations as well. Dr. LaCour asked another great question. How do you do a complete OB visit by telemedicine? Again, the answer is you're not going to, but if you've got someone like my wife who is not going to come in anyways, I mean, granted, it's her 7th baby, so I mean, she kind of knows what's going on, but the answer is, they don't. But I will tell you that our biggest health system here in Kansas City, or I should say our second biggest health system in Kansas City, is doing 100% of their OB visits just by doing it by telemedicine. So I don't know how they're getting away with that. I just know that I've had multiple OB patients tell me that they're doing everything by telemedicine. Maybe they're foregoing it. My question for you, Dr. LaCour, would be, show me the data on how that really makes that big of a difference, the data that you acquire. So fetal heart tones, does that make that big of a difference? I don't know. But I will tell you what does make a difference: prenatal care, making sure the mom's taking care of herself, making sure her mental health is doing well, making sure she has all the resources she needs, and that kind of stuff you can do by telemedicine. And I do agree with your comment. Better to have a limited exam than COVID. And that is a very good comment. So how long is my average telemedicine visit? I get asked that question a lot, and that's a good question. The answer is, I've noticed it's about half of what it would be if they were in person. I do think a lot of that, though, is because I'm a lot more chatty when I'm in person with my patients. And I seem to be a little bit more to the point in telemedicine. I still try to build a rapport with them, but it's a lot harder to do when it's in telemedicine. So I'm not as chatty with them. And so I think there are just half. One thing I love about telemedicine that I don't have when I do an office visit is the service I use, Doxy.me, is pretty cool. It has a little timer going on in the corner. So I kind of see how long I've been on with the patient. And that's kind of fun to judge how long I am versus when I see them in person. So I don't judge my how long I am and with my patients in the clinic, but I feel like I go through telemedicine quicker. Part of that, though, is because telemedicine is a little more focused. I'm not doing, most of these patients doing telemedicine are not, I'm here to follow up on 10 things. It's usually just 1 or 2 focused things that they're just trying to get taken care of right now, and then hoping to see me after this is all over. All right, any more questions from anyone? I got through all of them here. What is your billing for cash pay now that CMS is reimbursing? So we are billing just like we would for a normal code. So we have a set price for a cash pay, 99213. That's how much we bill for a telemedicine. So they pay for it. When my staff calls them, they take their copays up front if they want to do a copay. And so we'll do that up front. And so if they're cash pay, they just pay us up front with their credit card. We have a discount for people that are cash pay, but you have to pay it right up front. So that's why they pay it up front. We could bill them later. We give them that option, but then it's more expensive. So most people pay up front. Any tips from an audience who might also be using Microsoft Teams? That's what our system has switched over to. I wish I could tell you, Elizabeth, I just don't use Microsoft Teams that much for something like telemedicine. I will tell you, have your system check out Doxy.me. I do not get paid by these people, by the way. I know I've mentioned them multiple times, but I've been using lots of providers, including one of the most large chain providers. We hated the large chain provider system. It was complex, and it was like trying to get a circle through a square. They had designed their system to make it in the the pre-COVID world, and the post-COVID world is so much simpler. What I love about Doxy.me, it takes you 5 minutes to sign up. You get a website. So in my case, it's doxy.me/Smithville, the name of my town, so patients can put it in. All my staff does is tell them to go to that website. They can go on their phone, they can go on their laptop, and then they go in, they put their name, and it puts them in a waiting room. And that's it. And from my they don't have to download software. They don't have to install anything. It was so easy. I was able to do it with Brian. Sorry, Brian, I've got you muted, so you can't comment to that. But anyway, so with Doxy.me, it gives you a nice little waiting room that you can text all your patients that are waiting. You can be like, hey, I'll be with you in 5 minutes. It's a very quick, easy experience, and it puts them all in one place for you. So we switched over to that. The cool thing about Doxy.me too is it is HIPAA compliant, and you can get a BAA with them, which is the requirement for HIPAA compliance. So it would be valid after these rules and regulations go away. So there you go. Let's see here. Elizabeth said, I hope my house is muted. That is a true statement. I was talking to one of our oncologists the other day, and she said her hardest thing with doing telemedicine, they've been doing almost all their visits they can by telemedicine. And she said her hardest thing is when her kids come in screaming or yelling. And so, I think patients are pretty understanding. I think my patients just think it's funny and laugh. So I just tell them to excuse my coworkers for a minute. I've got to go put one in timeout. So that's kind of how we do it. Let's see. Alicia King asked, any suggestions for residents as we're starting to do more of this, especially with regards to documentation? I would say it's awesome that you're learning this in your residency. It's not even anything that was on my radar because it just wasn't available to us. I would just say get used to it because this is your future. Anyone that disagrees with that would be like saying that the movie theaters are going to be jam-packed the moment they take away all these restrictions. We know that's not true. We know that when they take away these restrictions, people are going to still be scared coming to the doctor's office. And so I think telemedicine is here to stay, if not forever, at least for a very long time, because we're going to have a lot of patients, even when these restrictions are lifted, that are not going to want to come here. So get used to telemedicine because it's going to be the only way we're going to be able to see some of our patients. Someone asked about joining a telemedicine company for moonlighting work. I am familiar with some of the groups, and I'll tell you, it's up to you. It's for me, I am a family medicine doctor because I like to do a little bit of everything. I do not want to be a full-time telemedicine provider. I like to see patients in my clinic. I like to do little procedures, but I also like to mix it in. My goal has never been to be a full-time telemedicine provider. It's to be a full scope family medicine physician. I've always just felt that there are so many of my patients that I could just do this by telemedicine. It would be much more convenient for them and easy for me. So if you want to do it full-time, great. Personally, I think I'd be bored. It's the reason I didn't become a dentist is because I could not do teeth all day. The reason I didn't become a podiatrist is because I couldn't do feet all day. I have nothing against those people. I like full scope. If you want to do telemedicine all day long, that's fine. But just know that that's what's going to happen if you start doing it more full time. Let's see. I found that established patients are the first to volunteer that after the telemedicine visit, then they want to schedule another visit for OMT. It's actually true. Telemedicine patients that are using it become pretty solid patients. They love it. I've not had any patient yet complain about telemedicine. They love it. And then I don't know about the Zoom OMIM appointment. That should be kind of interesting. Let me know how that goes. I do know you can do testing and diagnosis that way. You can have the patients move and show you different functionality. I guess you could work them through some yoga or some treatments or something like that. Hey, more power to you. I'm not going to say no to anything. Did Brian get a teleprostate check? I'll leave that for Brian to answer. So anyways, there's lots of things, it brings up an interesting point. One thing that makes you a good telemedicine provider is actually understanding the sensitivity and specificity of the labs that you draw and the tests that you do. A good example of that would be the urinalysis. We use urinalysis to diagnose UTIs. But if you look at the sensitivity and specificity of the UA, it's not very good. And if you look at the sensitivity and specificity of a history of a female with UTI symptoms, it's almost slightly better than the UA. And the only reason I bring that up, I'm not saying one way or the other. What I am saying, though, is that you can do a lot of medicine without the tests that we've become so reliant on. And one thing I've found with telemedicine providers is the ones that do really good are your older physicians, your more mature physicians that have been practicing for a while, and they're much more comfortable providing remote telemedicine because they're much more comfortable practicing without reliance on tests and with numbers. And so the people that I struggled with the most when I was training younger telemedicine providers were the ones right out of residency, the ones that had, and honestly, the nurse practitioners would struggle with this too, because they were so reliant at first upon those tests. And they'd forgotten about their skills of being a good historian and being able to get a good history out of the patient, because you can do a lot with a history that doesn't require a patient to come in. But the nice thing is now that if they do need labs, you can come up with workflows where they can get those labs and those tests. One thing I think you're going to see out of this, they've had them kind of hidden on the shelves before. I think you're seeing a lot of home tests coming out of this COVID experience. I think you're going to see some regulations go down where patients are just going to be doing home UAs. They can actually do those already. They are available at your CVS stores and things. But I think you're going to see a lot of patients being able to do more home tests and things like that, and then just communicating with you, possibly even not concurrently through those e-visit types to get the care. It'll be interesting to see where the world's going. The other thing I think you're going to see more of is the technology of home diagnostic tools. There are some devices, if you want to look at them online, that, for instance, there's an otoscope that has a screen on the back that uses the same technology that you use whenever you take a picture of a check. And you know how the technology, when you're taking a picture of a check for your bank, it centers it and tells you to move up or move closer or move farther away. Well, this tool is an otoscope, and it looks at the ear and it tells you what direction to move that otoscope until it sees that eardrum, and it has you move until you get it perfectly centered, and then it takes the picture. So you're going to see a lot of AI-assisted devices and home diagnostic tools that patients will have access to, so they can send you a full scope of information. This same otoscope, you can take off the otoscope attachment, put on a diaphragm attachment, and then it will guide you to the different parts of the lungs, and it will have you leave it there for 30 seconds at a time. So that way it sends a sound file to the provider as well, so that they can hear heart and lung sounds as well. So it's going to be interesting what comes out of this. The future is going to be quite interesting. Well, if that's it, I don't have any more things to do. I appreciate all of your time. I appreciate all of your participation. Feel free to reach out to me. You can reach out to me through the MAOPS office, or you can email me directly. My work email is michael.brown@meritashealth.com. It's michael.brown@meritashealth.com. Feel free to reach out to me if you have any more questions, or like any advice or assistance, or you have advice from me. I appreciate it too. One thing I love about doing these is that you guys bring your wealth of knowledge and sometimes make me aware of things. I wasn't aware of this Doxy.me until a couple of lectures I did ago, and someone pointed it out, and I've loved it. So keep the good information and feedback coming. Really appreciate it. So everybody have a good night. Thank you so much for your time.